So when we talk about floating hips, we essentially need to understand certain things about the classifications, understanding how these injuries happen, and what is the most sinister aspect of these injuries. I need to understand that a lot of times these injuries will have an ETC converted into a DCO, and I'll just do some very quick examples. So if you talk of classification and as Liebergal in 2002 defined these floating hips have a proximal component and they have a distal component. And the proximal component very often is an acetabular injury or a pelvis injury. And the distal component is a proximal femur fracture, a diaphyseal fracture, or a supracondylar femur fracture. So the proximal femur fracture can be a Pipkins, can be a neck fracture, can be an IT, or can be a subtrochanteric fracture. And then you have the diaphyseal fractures, which are usually the proximal, the middle diaphyseal fractures. And then you have the supracondylar femur fractures, pardon for the missing R. And these fractures are sinister for the simple reason that they are very frequently associated with vascular injuries and compartment syndromes. So the three patterns that we see, and if you want to classify them as to how we think about these fractures, there are type A, type B, and type C. Type A's are basically acetabulum fractures, which are associated with ipsilateral femur fractures. Type B are the ipsilateral pelvic injuries with the femur fractures, and type C are the combined pelviacetabular injuries with femur fractures. And then, of course, there is no classification for another type, which is, I will call it the type D, where you will have both a floating hip and a floating knee together in the same patient. So what is important to understand is that there are two patterns of injuries. One, where these are dashboard injuries, where the primary force which is going to damage comes from the knee or distal to proximal. And these are injuries where one will have the proximal third fractures of the femur, and they will have posterior fracture dislocations of the hip or posterior injuries of the pelvis. The second pattern is the lateral impaction injuries, and those are the ones where the primary destabilizing force comes from the greater trochanter. And these are the injuries which cause the anterior and the central injuries to the acetabulum and the pelvis, and they will cause distal third femur fractures. So what is important to understand in these injuries, that which are the injuries which will cause hemodynamic instability and which will cause a risk to life. And those are the APC3 injuries, the LC3 injuries, the vertical shears, the combined pelviacetabular injuries, and the popliteal artery damage and compartment syndromes. So when Ranjan talks about a missed compartment syndrome, it's very, very important, because very often we may have an artery going into a spasm, but also we may have an internal artery, popliteal artery injury associated with these injuries. So that's an LC3 injury where you have a force which is coming down from one side, which internally rotates the hemipelvis on one side and externally rotates on the other side. And then you have the APC. And what is important to understand is what is an APC. So when there is a force which comes from either anterior to posterior or posterior to anterior, it will cause an opening of the pelvis. And this opening of the pelvis causes a damage to the posterior venous plexuses in the ring and causes a damage to the posterior SI joint and the iliolumbar ligaments, and then thereby cause instability, which will cause a hemodynamically unstable patient. The other situations are the combined pelviacetabular injuries. And this is like a case of a bilateral transverse fracture with a symphyseal diastasis. And these are injuries which are very often associated with hemodynamic instability. The other patients are those where you have a combined pelviacetabular injuries where you might have a SI joint disruption on both the sides, which again are very significant injuries with a very significant force transfer. And these are injuries which very often will present with a hemodynamic instability and a risk to life. So the primary goal of management of these injuries is fluid resuscitation and blood transfusions and acute stabilization of the pelvic ring. You can do it with soft binders within the first 24 hours, or if you have a patient who's bleeding incessantly, they may need a pelvic packing or an angioembolization. The thing with angioembolization is that it takes some time even for the interventional radiologist to come in. So pelvic packing is what will help for a venous bleed, and angioembolization is what will help for an arterial bleed. And then you have to have emergent internal or external fixation in your armamentarium to stabilize these injuries and allow the hemodynamic stabilization to go on. So when it comes to definitive management of these injuries, one needs to have an MDI approach based on the physiologic status and accompanying injuries, as Sarabdeep very nicely elucidated. The average delay in fixation for these patients is about 5.7 days. And it's important to plan the position, the approach, and the reduction techniques when you do get to the definitive fixation. But the priorities are two. One is that your ATLS, and you do an ATLS with early total care, where you do the simultaneous stabilization and fixation of these fractures. And the second is that one does a staged management along with ATLS with soft tissue management, temporary stabilization, and definitive management. So here we have a type A injury where you have a fracture of the acetabulum and the fracture of the femur. So this was a 31-year-old male, sustained injury in a road traffic accident, had a Pipkin's fracture with a posterior fracture dislocation of the head. So we chose to do a KL approach and a safe surgical dislocation, and did an open reduction internal fixation of the head of the femur with Herbert screws, and we fixed the posterior and the extended posterior wall fractures with lag screws. This patient had a resorption of a severe combination of the posterior inferior fragment, which required autoiliac bone grafting, which was done from the iliac crest and was fixed with a neutralizing buttress plate. So this is the patient 6 weeks post-op and is apparently doing well, is now probably 13 months post-surgery. Another example is a type B pelvic. It is a type B floating knee, a floating hip, where you have a pelvic injury and a femur fracture. And that's another 39-year-old male, sustained injury in a motor vehicle accident, an open 3B right femur with an LC2 dislocation of the right SI joint and a low anterior column of the right acetabulum. Again, the key is that one has to do a DCO, a debridement, stabilization of the right femur, which was done on the first day. The patient was put on a pelvic binder, again taken in for a redebrima of the femur on day 4. And on day 7, he underwent an iliofemoral and a combined AIP approach with an ORIF of the sacroiliac joint and internal fixation of the pelvic or the low anterior column fracture with plates and screws. And this is what he looked like. Another case example, the type 3 injuries, where you have a combined pelvic-acetabular injury with a femur fracture. And this is again was a 38-year-old male, another motor vehicle accident, had a systolic blood pressure of 100/50 on presentation, had a blunt injury abdomen, had a comminuted fracture shaft femur with a vertical shear injury and a zone 2 fracture of the right sacrum, which was an islug grade 2 or 3. And had a disruption of the symphysis and a low anterior column fracture of the right acetabulum. So following his ATLS and his primary stabilization, he went into ICU care. His abdominal injury and the head injury was conserved. His abdominal injury and his head injury was conserved. And finally, once he was out of ICU, the RILS-2 of the head injuries, the blunt injury abdomen, he was taken up for a stabilization after day 8. And this is what was done for him. He underwent a limited ORIF for the femur, and he underwent a posterior tension band fixation and an SI joint fixation for the pelvis. Another example now, a floating hip along with a floating knee. So that's a 38-year-old male, road traffic accident, neurologically intact, pain and deformity with open wounds in the right forearm, right thigh, and right leg, and he had a moral level lesion. And these were his injuries. So he had a open segmental shaft femur with APC3 injury on the pelvis with open fracture shaft of the tibia. So that's the floating knee, and a open fracture both bones of the forearm. And this is where one has to go in for an HDI, which is a hemodynamic stabilization, followed by a damage control treatment. And then we come to the definitive fixation for the pelvis and the limb fractures. So the basic order of stabilization does not change. So one has to follow DCO, one has to treat the moral level, has to treat the soft tissue and the open long bone injuries, and then come to definitive management of the pelvic injury and the open both bone and the long bone fractures. So he underwent day 0 debridement and an X-fix placement for the tibia and the femur. with a WAC application, a repeated debridement on day 10, and followed by a flap reconstruction by the plastic surgery team. And on the third week, he underwent internal fixation for his SI joint and his pubic symphysis, and ORIF for his both bones of the forearm. On day 35, his wound over the wound over the thigh had healed and the flap had taken up, and he underwent a removal of the fixator with intramedullary nailing for the femur. And at the end of 2 months, he underwent removal of the fixator for the tibia, along with the IMIL nailing and bone grafting for the tibia. So that is basically what we did. We looked after the hemodynamic instability, did damage control orthopedics in terms of stabilization of the skeletal injuries and a binder for the pelvic injuries, took care of the moral level lesion, managed the open long bone injuries with a flap, and then we did a definitive stabilization of the pelvic injury with definitive management of the long bone injuries subsequently. So the take-home message for the floating hip pelvises is that it's a high energy trauma. It can cause a loss to life, and the priorities are saving life, limb, and function. One needs to be able to understand and classify these injuries. One needs to understand the biomechanics of damage of these injuries. Hemodynamic instability, very often, both subtle and very visible hemodynamic instability is the killer. So one has to be very clear. And damage control orthopedics is probably the key to saving this patient and getting them back to optimal function. Thank you so much for your time.